Okay, so chlamydia infection is basically the most common STI in humans and a leading cause of infertility in women. It's caused by Chlamydia trachomatis, and they're basically small gram-negative obligate intracellular microorganisms that infect preferentially the squamous-columnar epithelial cells. It affects the cervix, the uterus, openings, the uterus, mesopharynx, and epididymis. It has about 18 serovaes associated with different medical conditions. On the etiology, it's usually due to sexual contact through oral, anal, or vaginal intercourse. And the risk factors include black race, promiscuity, age between 15 to 24, usually younger than 19 years, and poor socioeconomic status, unprotected intercourse to colliterate, decreased immunity or immune dysregulation. The pathophysiology is poorly understood. Chlamydia infects columnar epithelial cells, which places this female at a higher risk because of the presence of the squamous-columnar junction on the ectocervix until early adulthood. Incubation period is between 7 to 21 days. The chlamydia have unique biphasic life cycle that is adaptable to both intracellular and extracellular environments. The cell destruction occurs as a result of the inflammatory response and the release of newly formed elementary bodies to infect newer cells. So the history, as you can see, the patient will complain of an unusual vaginal discharge, is bleeding between periods, pain or a burning sensation when passing urine, dyspareunia, postcoital bleeding, proctitis, low abdominal pain, sometimes with nausea, rectal discharge and fever. On physical examination, there is usually cervical variability, urethral discharge, thin and mucoid, cervical motion tenderness, dysuria, adnexal fullness, low abdominal um, tenderness too. The investigational patients with STDs should be evaluated for chlamydia infection. In Ghana, testing for chlamydia infection, routine or otherwise, is not usually done, and treatment is based on clinical evidence. In other countries, screening tests are routinely done. Specimens should be taken from endocervix, urethra, rectum, depending on the patient's sexual practices. MSSU can also be used. Molecular testing, direct fluorescent antibody testing, ELISA, DNA could be done. APTIMA combo 2 assay for rRNA PCR could be done for culture on HeLa cells or McCoy cells. This is not usually done, and also NAAT is a preferred diagnostic investigation. Antibiotic treatment, we have the primary treatment being azithromycin 1 gram orally once, or doxycycline 800 milligrams orally twice daily for 7 days. Alternative regimen, you can give erythromycin or fluoxetine, levofloxacin. All these may be used. In following treatment, retesting is not recommended if symptoms resolve. The general advice you give to your patient, you just should the patient avoid intercourse, including oral and rectal, before treatment of both partners is complete. The use of contraceptives, especially condoms, should be carried to prevent reinfection and other STIs. Retesting, if any doubts about complete treatment, should be done. The test should be carried out a minimum of 5 weeks after initiation of treatment, and tests of the cure should be routine in pregnancy. There are several complications that could happen from this infection. The main complication of chlamydia infection is PID, as pelvic inflammatory disease, which may lead to tubal ovarian abscess, ectopic pregnancy, infertility, chronic abdominal pain, miscarriage, and preterm delivery could also happen. Fitzhugh-Curtis syndrome is a rare complication of PID and is 5 times more likely to be caused by chlamydia than gonorrhea. Pregnant women with chlamydia infection can pass the infection to their infants during delivery, leading to chlamydial pneumonia or conjunctivitis.